how their programs are experiencing the world, how women and girls experiencing the world in various areas. So I'm very excited, and our Director of Grants and Partnerships, Dr. Veena Khandke, will be speaking. You want to say hello, Veena? So if they have
everybody.
speaker view, they can hear you, they can see you. Great. Also, our staff here is Wendy Fradlin. If you have speaker view, Wendy, can you say hello?
Hello.
Wendy is our Director of Communications and Membership, and she is managing the behind the scenes and all of that. A couple housekeeping things. Please mute yourself and keep yourself muted unless you are talking, and because it's going to be very hard for us to keep everyone muted. And please utilize the chat. At the bottom of your Zoom screen, you will see a orange button that's blinking. And if you click on that, you can bring up the chat and people can say hello to each other. You might type questions there. There's all different ways to utilize the chat. Wendy, if we ask for questions, it might be a good idea to type your question there so that Wendy can, or Veena can repeat the question for the whole group to see. And again, we have, right now we have 5 pages of people joining this event tonight. So I hope you're able to see some of your friends, and I encourage you to put on your video. I was so excited tonight that we had so many people that I got fully dressed. I mean, I have regular shoes on, so I'm just like, this is a very exciting evening that we're getting to see all of you. So please say hello and who you are in the chat, and we will start in just a minute. Wendy, how are you doing with letting people in?
Still letting them in.
Still letting them in. Okay. Do you want to put the dinner affirmation up, and we will ask Ellen Levy to read it. Some chapters utilize the dinner affirmation, some don't, but we love it at the home office. And Ellen Levy is a wonderful member of Dining for Women in Tucson, Arizona, and she joined us and me on our trip to Kenya in 2019. So I was excited to see her on, and she is going to read it. We're not going to read it together because we found that it's a little bit hard for us to all be in sync. So Ellen?
As we share food, we share something of ourselves, and we honor each other. We recognize the powerful associations of women to food, life, and nurture in all cultures. We honor the importance of those. We also recognize the burdens they can bring. We remember the women about whom we've learned, the ones they strive to nurture, and the organizations that are trying to nurture them. By eating together, we remember and honor those women who also have favorite foods and family recipes. And we express the hope that through our efforts, they may find more sustenance for their lives. May we all be able to feast together someday.
Thank you so much, Ellen. That was wonderful. I think now I'm going to turn it over to Veena to introduce our panelists.
Thank you, Beth Ellen. Welcome to our very, very distinguished panel today. We did put this panel together in a pretty short time, and so apologies for our relative informality, but that is what Dining for Women specializes in. We are pretty informal, but deeply, deeply committed. So I'm going to introduce each of our panelists. This is a very shortened bio. It would not do justice to the range of their accomplishments and their talent. but here goes. And I'm going to begin with Dr. Peter Navario, who is the Executive Director of HealthRight International. Peter, if you could wave so we all know you're there. He is a global, so HealthRight International is a global health NGO which is dedicated to improving the health of marginalized communities around the world. Peter is also a clinical assistant professor of health policy at New York University School of Global Public Health. He has had esteemed positions as a technical advisor at the Joint United Nations Program on HIV/AIDS. He's a fellow, has been a fellow at the Global Health and the Council on Foreign Relations. He's on the editorial board of the journal Global Health Governance. Peter holds a BA from Lehigh University, an MPH in Global Health from Yale University, and a PhD in Health Economics from the University of Cape Town. Welcome, Peter. Next, I'm going to introduce you to Jennifer Schechter, who is the Executive Director of Integrate Health. Jenny, you can wave so everybody sees you. Jenny has been building innovative healthcare solutions at Integrate Health ever since she served as a Peace Corps volunteer in Togo. Since taking on the role of CEO in 2012, Ms. Schechter has helped to expand Integrate Health's impact in the fight to end preventable deaths of women and children in Togo. Integrate Health collaborates with the Togolese Ministry of Health and has innovated to start a global movement to bring about systems level change in the way primary healthcare is delivered. Integrate Health has actually created a document that you can see on their website, and they are very, very well known for their innovations in community health. Ms. Schechter received a Bachelor of Science in International Politics from Georgetown University and master's degrees of social work and public health from the University of Washington. Welcome, Jenny. Next, I'm going to be introducing Kevin Schumacher, who is from the Women for Afghan Women grantee. He is serving as Deputy Executive Director and works very closely with the program and operations team in Afghanistan. He supports finance, communications, and development teams in New York. He has close to 20 years of experience in grassroots organizing, human rights documentation, political research, sexual rights and gender equality advocacy, refugee assistance, media outreach, and safety and security training. He formerly served as the regional program coordinator, also the communications coordinator, for the Middle East and North Africa at Outright Action International. This is an international human rights advocacy group. Kevin is bilingual in Farsi and English. He has an advanced comprehension of Arabic and understanding of Turkish. He has an MA in International Relations from the National University of Tehran and an MA in International Peace Studies from the University of Notre Dame. Welcome, Kevin. Then we have Joanna Sherman. She is the artistic director of Bond Street Theater. Joanna, you can wave. She has conducted over 500 several projects in 50 countries worldwide, which aims at peace building in post-war communities, while focusing on the concerns of women, children, refugees, LGBTQ, and other marginalized communities. Under her directorship, the company has received a MacArthur Award for its intercultural programming. She herself has received several awards and is a cultural envoy in Myanmar and India and has served in these positions. She has been a speaker on the role of arts in peace building. You will often hear her on CNN, and Joanna is all over the world, changing the world. Last but not least is Dr. Mark Sklar. He is an obstetrician and a gynecologist. He is with Brick by Brick Partners. You can wave, Mark. Mark has worked for Brick by Brick Partners for a very long time. He has worked in the areas of maternal and newborn health, reproductive health education, and establishing Brick by Brick's company, a local social enterprise that utilizes environmentally sustainable technology while providing a sustainable source of income to the communities. So all our distinguished panelists, we have extended bios for them. I believe Wendy must have email them to all of you. But for now, I'm going to call on each one of you to talk about your work in your organizations. Dining for Women has focused often on the projects that you have done with our grants, but we would like to hear from you about the range of projects that you are doing. So I'm going to begin with Mark. Hello, Mark. How are you? Mark? There you go. How are
Sorry,
you doing, Mark?
I'm fine, thank you. Yeah, I apologize if the sound is a little strange. It's because I live in a one-bedroom apartment with my wife, who's a PhD student and professor, and she's in the middle of teaching right now. So my office becomes, in those situations, the half bathroom that we have here. So I have a desk set up. So this is the kinds of compromises we have to make when you're married for 28 years to a professor. So, if the sound is a little echoey, it's because I'm actually in the bathroom, but I promise you I'm not multitasking here. So
go ahead, Mark. I think I can share with our members that you are recovering from COVID,
yes,
and I believe you're fully recovered. So why
I
don't you
am.
go ahead and tell us about Brick by Brick Partners, and then tell us about the Dining for Women grant.
Yeah, so Brick by Brick is a binational partnership between Brick by Brick Partners, which is a 501c3 here in the United States, headquartered in New York, and a Ugandan community-based non-government organization, which we have been working in 2 districts of Uganda with a population of about 518,000 people. They are rural districts, about 3 hours south of the capital of Kampala, since 2004, so about 16 years. Our programs, we have a sort of wide array of program initiatives, but primarily they focus on maternal and reproductive health. Myself and the co-founder of Brick by Brick, we are both public health obstetrician gynecologists. So not too surprising that we would focus our efforts in that area. We began working together almost 20 years ago on a cervical cancer screening study funded through Johns Hopkins School of Public Health. The Rakai district is very important historically. It is where we now believe that some of the very first cases of HIV actually emanated from, way back in the early 1960s, long before the pandemic was recognized. And so it has still dealing with the really catastrophic effects of prevalence rates that at the height of the pandemic reached almost 30% in our communities. So we have 3 core programs. One is called the Babies and Mothers Alive program, and that is the program in which our project that is funded with Dining for Women, which I'll speak about in a bit, is nested. It's a fully engaged partnership with the Ministry of Health and the district health departments of our 2 districts, working in 48 free government-funded health facilities, essentially all of the public facilities that provide maternal and newborn care. And over the past 4 years, we have been able to realize dramatic reductions in maternal and newborn mortality of close to 79%, and really dramatically improve the quality of care in those 48 facilities through a model that focuses on full partnership and actually empowering the local midwives, a group of 30, what we call a core group of about 30, what we call mentor midwives, who are the actual implementers for our training and mentoring program in these 48 health facilities throughout the 2 districts. We also have a program that focuses on adolescent reproductive and sexual health. It's called MyPads program, and it targets both in school and out of school boys and girls to empower them with knowledge and skills, life skills regarding sexual and reproductive health, linking them to adolescent-friendly health services with nurses that we, through the Babies and Mothers Alive program, have trained to provide really high quality reproductive and sexual health services. And we also have a school program that works to improve primary education in 9 free primary schools, serving about 5,000 children. The project that we're funded through Dining for Women is called the Mama Rescue Project. And it is a project to link women in labor to existing transportation resources, motorcycle taxi drivers and automobile taxi drivers, through a mobile phone application that allows those drivers to be paid immediately when they bring a laboring mother who's registered in the program to a health center, or when an automobile taxi brings a mother who's in need of emergency referral from the health center to the hospital. We know that 90% of women who die globally, about 385,000 women die every year from complications of labor and pregnancy, that 90% of those women who die do so because of one of 3 delays. The delay to seek care, the delay to get to a facility once you've made the decision to seek care, and the delay to get good quality care once you arrive at a health facility. So this Mama Rescue Project is primarily focused on the second delay, to try to deal with what has been a really stubborn problem for us of dealing with long delays once mothers decide that they want to come to one of our partnering health facilities, but end up spending hours and sometimes even, approaching a day getting to a health facility because of lack of funds and lack of resources to actually get transportation. So that's the project that Dining for Women has funded. Fortunately, we have also, after the Dining for Women grant, we also received 350,000 euros from the Belgian government to fund this project, which really is allowing us to really envision a full-scale initiative. When we first proposed this to Dining for Women, we were thinking of it as a much smaller pilot study, but now with the Belgian government's support, we really envision this being able to be rolled out to the entire 2 districts. Veena, I don't know if you want me to talk about some of the challenges that we're facing with COVID, or do you want to stop?
We'll come to that. Yeah,
yes,
we'll come
sure.
to that. Mark, you clearly have been working with governments. So I'm going to move on to Joanna. Joanna has worked with so many different countries, so many different governments and international entities. So it takes a lot of effort to build those relationships, to build the trust. Joanna, tell us what Bond Street Theatre has been doing.
Bond Street Theatre uses theater and the arts to spread the word, to address social issues, depending on what they are, in various places in the world. So we're adapting the arts to these various situations in different countries. So, for example, refugee communities, we mentioned that, and shelters, prisons, rural communities, depending what the needs are. I always say the theater's good for 2 things. It's very good for carrying information that's difficult or about sensitive topics and bringing it to places that are not able to access this kind of information. So, for example, in Afghanistan, we created these all-women's theaters, and the women had perhaps, these girls mostly, I guess between the ages of 15 and 19, some of them had never seen theater at all, and in a couple of weeks, we turned them into actors, and for the elections in 2014, we created a show about the elections. Why vote? What is voting? What good does it do? What good does it do for you as a woman? How is it that women have the right to vote? And this was very successful because they could go right into women's homes and perform their show about voting right in the women's homes. So theater is extremely adaptable in this kind of situation. Also, just theater training. Sometimes we're just doing leadership training, or getting people to talk about what their issues are and how they want to advocate for it. So I know we're going to talk about advocacy, but we do a lot of advocating. For example, another program that we did in Myanmar, Malaysia, with Rohingya refugees. again, forming kind of a theater group among the Rohingya women, and they could advocate for the fact that refugees have very few rights in Malaysia because they have not signed on to the UN conference on refugees. So they can't send their kids to school, and they have limited access to health care and limited access to, they're always afraid of being detained, et cetera, just like in many countries. So they could advocate on their own behalf to UNHCR, but also to the local government, because that's really the essential thing, to advocate to the government. For Dining for Women, we'll be working again with the Rohingya women, and we'll be working again in Afghanistan. You know, I was speaking about the women's theater companies. Well, they introduced us to the idea of performing in the prisons, because there again is a situation where they don't have a chance to get this kind of information about voting, and they can't vote in the prisons. So we organized a program that was sponsored by Dining for Women, thank you very much, to go into the women's prison in Herat and specifically work with those women, which we did for a full year. It was very, very effective. And this kind of leadership training, or how to express yourself, or it builds the self-confidence so that they can advocate on their own behalf. And the justice system is particularly problematic, not just in Afghanistan, in many places in the world. You know, we're also working in South Africa now. So again, it's a situation where women do not get a fair shake in terms of the justice system. So they can do what they can to advocate on their own behalf, and work with lawyers, and work with the women lawyers that come in and work with them. And besides working at the women's prison, we also work with the Juvenile Correction Center and the shelter. After they get out of the prison, they can't go back to their home, so they go to the shelter. So we work with those women there. So it's building their capacity to, and their motivation to speak out and feel like a whole person, to feel very clear about what they want to say and what they want to do with their life, and give them a direction and that confidence to move forward. The programs coming up, I think we'll talk about in a while, the ones that have been sort of shuffled aside, because I know we were supposed to go to Afghanistan in June, and probably that's not
going to happen. Well, Joanna, thank you so much. Absolutely. Thank you so much for giving women and girls agency in the communities that you're working in, to give them a voice so that they understand what their rights are, and then they can move forward. So let me then now move to Kevin Schumacher, who's worked in Afghanistan, and this is about working with communities that have experienced gender-based violence. So Kevin, can you tell us about your work, and particularly the Dining for Women project too?
Yes, thank you for having me, and many thanks to the generous support of the women of the Dining for Women over the past few years for our work. We work as the main implementing partner of the Afghan government in supporting women's rights across Afghanistan. We are the largest women's rights organization in the country, with over 900 staff in 16 provinces right now, providing services to women who are survivors of domestic violence. We work with children whose parents are incarcerated, and we also offer a lot of social services and trainings to the community, especially about gender equality and women's rights. We have been working as part of the partnership with Dining for Women, especially in terms of the medical support for survivors of domestic violence. There is a great need for many survivors who need emergency medical support. Unfortunately, Afghanistan has a very weak medical infrastructure, which does not really allow for the treatment of these survivors inside the country. So we need to sometimes negotiate their travel overseas, working with different countries, and also a very costly process to basically take them overseas for multiple operations in order to treat them. Some of them are survivors of acid attacks, survivors of severe burns, etc., etc. So this has been part of the core work that we've been doing with the funding that we received from Dining for Women, but also we provide basic dignity kits to these women. A lot of the clients who come to our centers, we provide mediation and conflict resolution on the family level. And we often find these women are marginalized, so in a way that they cannot financially support themselves. If they need any medical needs in terms of hygienic needs, in terms of even basic ailments that they have, sometimes it's very difficult for them financially to afford the treatment. And as part of this program, we identify these clients who may not be able otherwise to receive the medical care that they need, and we provide them with services that we basically could afford through our network across the country. As I mentioned, the work that we do is primarily with survivors of domestic violence, but we are constantly trying to work with different segments of the population, including a lot of refugee returnees. Afghanistan, unfortunately, because of the almost 4 decades of civil war, they have millions of people living in neighboring countries, including Iran and Pakistan. And especially in the past few years, there has been mass deportation of Afghan refugees from neighboring countries. Part of our outreach is also with these refugee returnees who come back to the country. We try to identify their needs. We try to connect them to the local communities. We will also try to provide the services, essential services that they need. Lastly, I just want to mention the kind of work that we do in terms of the education for women, because we feel that part of our mission to empower women can happen through education. We are also negotiating with universities outside Afghanistan to provide a scholarship, merit-based scholarship for Afghan women who are qualified recent graduates from high school who do not have economic means but otherwise are extremely talented. And we try to support them in basically receiving education overseas, either undergraduate, or right now we're negotiating to see if we can have the same opportunity for graduate students outside Afghanistan, so that they basically are offered opportunities that unfortunately otherwise won't be affordable for them. I stop here and then we will talk about other programs that we have through the rest of the program.
Sure. So thank you, Kevin, for giving us a wonderful description of that. And the key point that you brought up was access to services, access to reach out to these women, things that we're seeing playing out all across the world now with the COVID pandemic. Next, I'm going to go to Jenny Schechter. And Jenny, if you can tell us about the work of Integrate Health and the Dining for Women grant.
Sure, thank you, Veena. And really happy to be on the line with all of you tonight. So Integrate Health works in Togo, a small country in West Africa, essentially to transform the way primary healthcare is delivered. So Togo is kind of an off-the-radar country that does not get a lot of support, a lot of international aid, and as a result has a very, very weak healthcare system. So the population of Togo is 8 million, and the government estimates that 70% of that population doesn't have access to basic healthcare. So that's what we're working on. We are working very closely with the government, with the Ministry of Health, as well as with local communities to strengthen healthcare delivery at the primary care level. So really focused on maternal health, helping women have safe facility-based deliveries, child health, addressing the major killers of children under 5, which are very treatable diseases like malaria, diarrhea, respiratory infections, and focused on sexual and reproductive health as well to make sure women have access to family planning services. And the way that we do this is through an integrated approach that pairs professional community health workers with improved care in primary care clinics. And so the work that Dining for Women is supporting is expanding our program to new sites and specifically supporting the community health worker component. So I'm just gonna take a moment to give a little bit more detail on that. Community health workers are women who are recruited from their local communities and trained, equipped, supervised and paid to become full-time healthcare workers. They actually go door to door and identify sick children and pregnant women, and they can provide care to patients right there in their homes. And they can also make referrals to the clinic for patients who need advanced care. And it's an incredible way to decentralize healthcare, to bring healthcare out to patients so that they don't have to travel to clinics. It's also a really incredible way to employ and create job opportunities for women. We see lots of secondary benefits from women once they become employed as community health workers, in that they can take care of their families. They can start to invest in other women-led businesses. So we're really excited to have the support of Dining for Women to expand that. Integrate Health started this program also with Dining for Women support in 2015, and we ran a pilot in 4 communities over 4 years, where we actually saw a 63% reduction in the under 5 mortality rate in those communities. And that led us to work with the government of Togo, with the Ministry of Health, to expand. And so we're now scaling that program to 25 facilities, serving 250,000 patients over the next 2 years. So we're very grateful to be partnered with Dining for Women. And yeah, maybe I'll leave it there, Veena.
Sure. Thank you, Jenny. All about public health and all about access to healthcare. So Peter, I'm going to come to you to tell us about the projects that HealthRight International has been doing, and the project with Dining for Women.
Sure. Thanks, Veena, and thanks for inviting us tonight. It's great to be with everybody. First, just a couple of words about HealthRight as an organization. HealthRight was founded 30 years ago. Actually, this is in 1990. This is our 30th anniversary, by health and human rights pioneer Dr. Jonathan Mann, who many of you are probably familiar with. The mission of the organization is to improve the health and well-being of marginalized communities around the world. We do that in a way that's not dissimilar from Integrate Health. We work at the community level to link marginalized communities to the public health system, and we do that through strategic partnerships between HealthRight, local community-based organizations, local NGOs, and the local government. And so we bring global resources to bear on local challenges. And we employ a very localized approach. HealthRight is a global NGO. We only have 9 employees out of 300 in our headquarters in New York. We don't employ expats at all. Everybody who works for us in Kenya is Kenyan. Everybody who works for us in Uganda is Ugandan, et cetera. And members, and very often members of the communities that we're working with. HealthRight works currently in 5 different countries: Kenya, Ukraine, Uganda, Vietnam, and the US. And our work is organized around 4 key population portfolios. Those portfolios are women and children, at-risk adolescents, migrant communities, and sexual and gender minority communities, which is our newest portfolio. And then we have cross-cutting technical programs, one in mental health and another in HIV. And so the Women's and Children's Health portfolio includes our work on maternal and child health, sexual reproductive health, and gender-based violence prevention. But our gender work obviously transcends all of our portfolios. So yeah, that's a bit about HealthRight and the work. Broadly, it's community-based health system strengthening and really working to find creative solutions to link these marginalized communities where we work to the public health system. The project that Dining for Women is supporting us for 3 years is adapting an intervention called Self-Help Plus. So this is a mental health intervention, and in the version of it that we're implementing with support from Dining for Women, we're focused on mothers. So bringing this mental health intervention to mothers who are also refugees residing in northern Uganda. And this mental health intervention is a 5-week intervention that is a guided intervention you do in groups. It's very low cost, and it's been shown to be effective with a variety of marginalized communities in low-income countries. I've in the group chat, I've put a link to a paper that we published just last month on the intervention in Lancet Global Health for people if they want to read more about the Self-Help Plus intervention. And so we're bringing this intervention, as I mentioned earlier, to mothers, refugee mothers in northern Uganda, to address the various mental health challenges that they have. One of the things that we've been working on at HealthRight in particular is integrating mental health into all of our public health interventions. It's a massive gap in global health and development, and one that we're trying to address at the project level in all of our projects. And so we're really excited about the opportunity to bring this intervention to refugee mothers in northern Uganda. So I'll pause there, and I'm happy to answer any other questions about the project.
Absolutely.
Nice.
So just to let our Dining for Women members know that these 5 grantee panelists were intentionally chosen. We selected them because their home offices are in the state of New York and Massachusetts that are currently being hit really hard by the COVID pandemic. So my next question to all our panelists is, how is COVID-19 impacting your home offices, your staff, your communities right here in the United States? And how is it impacting your beneficiary communities in your different countries that you work in? So in the interest of time, go ahead and tell us about all of the above, and as well as all the adjustments that you are making in the present state of affairs. So Peter, I'm going to start with you.
Sure. We've been, I think, very fortunate so far. Here in New York, we've been working remotely since the first week of March, and all our staff here in the States are fine. All of the staff around, we've got about 300 staff around the world. Everybody's fine. We don't have any cases, no confirmed cases so far. It has obviously impacted operations. I would say, with the exception of one of our grants in Maine, all of our projects are, and we've got about 30, are fully paused or partially paused. And so it's impacting our ability to obviously deliver on the interventions. Travel in Kenya and Uganda, as some of the other panelists will be able to attest to, has been curtailed. So it's very difficult. Nobody can really move or get around. So it makes implementing very difficult. And so we've been working closely with all of our donors on a project by project basis to try to either adjust the milestones and the targets for the project. And different donors are taking different approaches. Some have offered us the opportunity to convert our grant for this year to general operating funds. 2 have done that. Others have provided additional bridge funding, an additional 3 months to sort of get us, of staff costs to sort of get us through. So we've been really, really pleasantly surprised by the response of donors. Everybody's been really, really responsive, very supportive, and trying to work with us on all of our projects. So we're optimistic that hopefully once we get this behind us, we'll be able to get operations up and running. We'll have to see how this unfolds, particularly in Kenya and Uganda. The peak is, I think, still approaching, and I'm really pessimistic, obviously, about both of those countries' ability to respond. And I'm concerned that we're going to have a lot of silent deaths in these countries, because I think people are just going to, people who get sick are just going to end up, they're going to struggle to get to a health facility, and the health facilities aren't going to be capacitated. We are working with 4 counties in Kenya where we've been working for 15 years to procure PPE for those counties. We're not a humanitarian organization. We don't do logistics, but we are deeply embedded in those counties, and we have some relationships with organizations that provide commodities, including PPE. And so we're working with local governments to see what we can secure for them and get that to them. So we are in the process of trying to do that as well.
Absolutely. So flexibility is the name of the game for everybody. A reminder to Dining for Women members that the Dining for Women board has approved that all our grantees can take their grant money and use it in flexible ways. They could use it for operating funds during COVID-19. They could also use it for the original projects that were approved. And so we are giving our grantees flexibility in their ability to use their grant funding. Next, I'm going to go to Mark. I know Mark has another meeting at 8 o'clock in his, I don't know, new office. And so Mark, tell us what it's been like. You're still muted.
Sorry about that. Almost all of our staff, we are very, very lean and mean here in the United States. We have over 50 staff in Uganda, but just me here in the US, basically working as both executive director and development director, resource mobilization and grant writing. So I don't have a lot to report in terms of our US operation, other than 100% of our American staff were afflicted with COVID, since unfortunately I had my COVID adventure already. Good news was that it was, for a 65-year-old man, I managed to get through it, pretty much okay. And so I'm going to focus mostly on how we're dealing with it in Uganda. As was just reported, Uganda is, a few months behind the U.S. in terms of the COVID outbreak. I would perhaps paint having worked there for the last 20 years, I would paint maybe a little bit more optimistic picture of their response. Unlike the United States, within 24 to 48 hours of the first case reported about 3.5 weeks ago, the entire country was shut down. That means all schools were closed, all markets that do not sell food were banned, all religious services were banned, all transportation was banned. That doesn't mean just public transportation. That means you can't go from place to place in a car anywhere in Uganda for the last 3.5 weeks. So they are in a state of shutdown that we have yet to even approach, even in New York, the epicenter of the pandemic. And for that, we have gone from one case in about 3.5 weeks ago to, I think the last I checked, it was 79 cases, but no evidence of community spread as of yet. Of course, like the previous speaker, we are concerned that there may be silent cases, but the interesting good news maybe is that we have yet to see a significant number of patients presenting to health centers and hospitals in Uganda in respiratory distress. And while we know that there may be patients suffering in the villages and not getting to the health centers, it seems unlikely that if there were a significant problem with COVID right now, that we wouldn't have seen a single case or a single confirmed death due to COVID after 3.5 weeks. So we are, how can I say? I mean, I think we are very concerned, but cautiously optimistic that the social distancing that has been enforced by the Ugandan government very, very proactively and early in their COVID exposure may be effective in dampening the curve. Like I think most programs everywhere in the developing world, we are pretty much shut down right now. We are trying to support especially the most vulnerable mothers that we have. One of our core programs is a peer support group for about 700 adolescent mothers that it creates peer support groups over a 15-month period. And we are doing a lot of work now to get nutritional support to the babies and mothers, many of whom are isolated in villages. And because there's no transportation, they can't get from place to place. So we have we have been able to secure PPE for all of our staff, so we're able to go into the villages safely and to sort of do whatever mitigating activities we can to try to address the acute crisis, which for us right now is not so much related to health impact of COVID, but rather the economic impact of shutting down the country. And obviously, we are in districts that are where 70 to 80% of the population is below the poverty line. Many of them already not in the cash economy, so not being able to go from place to place to sell their foodstuffs in markets, not having any transportation at all by even motorcycle taxi is puts them in a real challenging position. In terms of the project that Dining for Women is supporting, it's a transportation initiative. So naturally, it was about to launch right before the shutdown, and it is now sort of in a holding pattern as we hope that there will be some easing, especially of emergency transportation for laboring mothers. We've been working with the Ministry of Health, trying to get them to agree to allow at least that kind of emergency transport and not shut down all sort of public transportation in our area. But that's a work in progress. So I'd say we're also I'd say in the context of what we're talking about in terms of development organizations, we're a relatively small NGO with a budget of under $1 million. So for us, the other impact of this is real concern about our revenue and our individual donors. We know that in the United States, obviously, we're about to go through at least a very severe recession, if not depression, over the next 6 months to a year. And we're obviously very concerned about the impact that will have on our budgets and our planning. So we are doing a lot of various scenario planning of how we can contract our programs, hopefully make them more efficient so that we can continue and not have to do, for example, mass layoffs of our staff and put them in the same precarious positions as many of our communities are already in. So that pretty much, I think, sums up where we are with COVID.
Mm-hmm. So Mark, and for all of our 5 panelists, the Dining for Women community is rooting for all of you who are risking your health, life and limb to bring all these services to your beneficiary communities. We are rooting for you, please remember that. And Mark, given that the project that we are funding is your boda drivers, your motorbike drivers, getting the pregnant with laboring women to hospital. I did see a question about that, and yes, it's often a female driver on the motorbike who's getting the pregnant woman to hospital. So if transportation is banned in Uganda, what's happening to the pregnant laboring woman?
Well, we are actually, we have a special sort of dispensation for our vehicles. So we have actually been engaged in actually transporting women. Of course, we can't transport thousands of women with 3 vehicles, but we have been doing that in the case of emergencies, serving as extra ambulance for the district health system. And sadly, we know that women are getting more and more delayed in terms of reaching health facilities. So far, we haven't seen any deaths in the last 3.5 weeks due to COVID. That doesn't mean women aren't dying. We're talking about deaths that we can report in the health facilities, the 48 government health facilities. So far, we haven't seen a bump of deaths due to this delay in transportation, but that's certainly one of the potential possibilities. And that's why we have been talking about advocacy. We've been meeting with the Ministry of Health, trying to get them to agree to ease up some of these restrictions. The problem is, of course, once you give boda drivers the opportunity to transport pregnant women, they're not going to just transport pregnant women. They're going to start transporting other people. So it's a very, very hard sort of logistic challenge for the authorities in terms of trying to keep everyone in place and keep them safe. So it's not easy. I wish I could say we have easy answers, but we don't. We're just really hoping that the actions of the Ugandan government have sufficiently slowed and dampened the curve so that we may come out of this a lot sooner than, for example, we will see here in New York, where we are likely to be dealing with significant social distancing, perhaps for the remainder of the year, and certainly through the summer and into the fall. That it's we're hoping that in Uganda we may come out of it a little sooner, but that's right now is kind of just a hope and a prayer.
Absolutely. Well, let me go to Jenny. So Jenny, so your community health workers, how are things going on in Togo?
Yeah, thank you, Veena. I will say that we have a dual focus right now. So our team did a really amazing job of responding very, very quickly to the pandemic and have mounted a really significant response in terms of getting PPE in, not just for our staff, but for our partners in the Ministry of Health and supporting the Ministry of Health response. But while we are working very hard to respond to COVID, we're also working very hard to continue the provision of primary care. Because what we know is that, and some of the panelists alluded to this, in places like Togo, where the case rates are still low, Togo's at about 115 confirmed cases as of today, patients are at a much greater risk of dying from lack of access to routine health care than they are from COVID. And so we have to make sure that they continue to receive that care. So fortunately, we've been able to equip all of our community health workers with PPE. They've always been equipped with gloves and hand sanitizer. That was a routine part of the supplies they carried in their backpack, but we've added face masks so that they can be additionally protective. And we've put in place some protocols that allow distancing to the greatest extent possible. So I'm very, very happy to say that our community health workers and our clinics are still open. Our community health workers are still working. We actually gave everyone the opportunity to opt out who wanted to or who didn't feel safe working, and they could choose to stay home and continue to receive their salaries, and everyone chose to continue working. The way they said it was, our communities are depending on us. They know that we're the ones that provide them healthcare. What will they think if we decide to stay home? What I thought was really interesting was that our community health workers were very scared in the beginning. And I really credit our team for recognizing this and for addressing it head on. And so they went out immediately and to the community health workers and said, what are your concerns? What are your fears? And what are you hearing from the community? Because community health workers were worried for themselves, but we also had community members who were worried and were saying, is it safe for me to allow a community health worker into my compound? So right away, the community health workers were all equipped with education messages on COVID, and they routinely start every visit talking about the pandemic and talking about precautions. And we're seeing really incredible things. We're seeing patients building hand washing stations in their homes. They're getting the messaging that's going out both through the community health workers. We're also doing radio spots with the Ministry of Health in multiple local languages, posters up at all the clinics. And I love this, we're using a traditional communication channel in rural villages in Togo that are actually the local drummers. And so local drummers will usually go around banging their drums saying, everyone please come out for a meeting at the chief's house tomorrow. Well, now the drummers are actually going around saying, you need to wash your hands, and giving messages about COVID. I just wanted to make one last point that's really stuck with me throughout this experience, because I live in New Rochelle, which you may have heard of because we were the epicenter of the epicenter just in Westchester County, just north of New York City. And especially in the early weeks as the pandemic was growing in New York, our team in Togo was so concerned about our staff in the US, and they were so just beside themselves with worry and calling and checking on us every day. And it was a real kind of, flip the script moment where we have all of Togo worried about how bad things were in New York. And you know, it just reminded me that we're all human and we're all susceptible to this pandemic, and we all need the same access to healthcare. So that's what's happening on our end.
And everything is safe at your end, at your offices and everything?
Yes, everyone is safe. Everybody's been working remotely, and yeah, everyone's safe. Thank you.
Absolutely. Flip the script is the name of the game. I mean, we are seeing so many similar things going on across the world, regardless of whether we're in the Western world or we're in other parts of the world. So Kevin, can you tell us a little bit more? Because gender-based violence is such a major topic about the risks that so many women are facing during this lockdown. Kevin?
Sorry, I was muted. So there are a couple of things that I want to mention briefly. One thing is about the work that we do here in the United States. We are headquarters here, but we also have a community center which serves new immigrants and asylum seekers from South Asia and Afghanistan. And unfortunately, a large number of our clients have been struggling with financial issues, but now with the pandemic, we had a number of clients and the extended relatives, unfortunately, passing away as a result of that. And our staff working remotely have to check on them on a daily basis to make sure here in the US they have access to healthcare, they have access to financial resources. We had to negotiate with different funders to seek financial assistance for the families. Some of the women that we work with are survivors of domestic violence. If you happen to be a survivor of domestic violence during these turbulent times, it's not really difficult to find a place to go to. So we've been working with the audience here in the United States, with the clients that we are serving here, to make sure that our services are basically provided to them. And even though a number of our staff have been dealing with the COVID-19 themselves, me included, we have been trying to do the best we could to be there for our clients here in the United States. But going to Afghanistan, I just want to say that the problem is much more different, in the sense that in Afghanistan, we're not only talking about a medical crisis, but rather an economic and food crisis. The first thing that happened in Afghanistan was the shortage of food. Right now, because of the lockdown in major cities in Afghanistan, most people cannot basically go out and try to make a living. The price of food has skyrocketed in a country that in average families have a monthly income about $150 to $200 a month. Not being able to make the basically living on a monthly basis means that you have nothing to eat. So the first thing that came to our mind for our staff and our clients was the issue of food security. What does this crisis mean to us? We immediately went to the donors and asked for some cash advance so that we can provide for our clients. We have over 1,000 women in our shelters and 400 children that are staying with us day and night. So it is a situation that we cannot stay there without food. And no matter what, no matter how expensive the food is, we have to make sure that the food is provided to the women who rely on us and the children who are relying on us. So we managed to negotiate with different donors an arrangement so that they can provide us for the cash advance that we needed for the next 3 months. Unfortunately, the food price fluctuates from day to day and from region to region. But thankfully, we've been able to take care of that part of the business. The medical shortage in Afghanistan is a serious problem. Afghanistan, unfortunately, does not have a very sound medical infrastructure. Often for more advanced cases, they have to send the patients to neighboring countries, namely India. Right now, there are no flights between different countries. So whatever is happening in the country is whatever you have. And adding more complication to that, our biggest donor is the US government. The US government instructed us not to purchase any PPE Long story short, because they do not want to create a situation where other countries are competing with the domestic US needs. So we have to be creative in terms of raising funds privately or through other donors in order to provide for the basic medical needs of our clients. Thankfully, the spread of the coronavirus in Afghanistan has not been as devastating as it is here in the United States. The cases are less. Nonetheless, as I said, the serious concern that we have is the lack of infrastructure in the country that does not allow the staff and also the clients to have access to medical needs that they have. We work with our teams across the country, with our team members to put in place a very extensive protocol for all our centers, from basic code of conduct during the coronavirus in terms of how many people are allowed to basically come to the office every day, in terms of changing the shift of the supervisors and the guards at every shelter. We negotiated with our staff. Our staff used to have 24-hour shift. Right now, in order to limit the exposure of outside elements to the center, we asked the staff to serve 1 week to 2 weeks each at the center so that there is less chance of people being exposed to the pandemic. We also have put in place certain protocols in order to protect our clients. Any new client that we get is screened for 2 weeks before being let into the center so that we make sure that the disease is not being spread inside the center. We also translated a document from English. New York Times last month published a guide how to make face masks. So we've been using that guide, translated into local language, and ask our clients to basically use the resources. We have vocational training for our clients. We ask them to make face masks for our staff and clients as well, so that we don't have to rely on the market and the donor for that. It's a struggle all around, but I think that together we've been able to take care of the basic emergencies. Unfortunately, the long-term view is very unclear, as most of the panelists mentioned, in terms of the donations. We don't know how the long-term is going to look like. We don't know how the economic outlook in this country will impact the situation of fundraising here in the United States. Unfortunately, the Afghan government does not have any resources to provide for the needies in the country. So far, the only thing the Afghan government has provided is to provide close to 10 pounds of wheat to 1,000 families. That's all they could have afforded since the start of the pandemic in Afghanistan. So it's up to the international community to do the fundraising and provide for the essential services that the people of the country need. And we are basically negotiating every day with different donors to see where we can get the resources for the next few months to operate.
Absolutely. Kevin, thank you so much. So Joanna, if you can tell us about what exactly Bond Street Theatre is experiencing, and you work in so many different countries, so pick a few to tell us about the present state of affairs.
First of all, I was just responding to what Jenny said. Others are calling us to find out how we are. So when someone comes from Afghanistan and calls to find out that they're worried about how we're doing, it's ironic that it's a disease that's bringing the whole world together. I think this is the only thing in my memory, and maybe in history, that's really brought the whole world together with the same, fighting with the same issue, of course on different levels, but still it's the same thing we're dealing with. I'm used to working remotely, as far as, working in our own location here. I'm used to working on remotely because everyone is everywhere. Our small staff, we sent them home so that they're where they are, but we communicate all the time, and it's fine. Our staff in Afghanistan and South Africa are both, but they're all locked down. South Africa, I think, has the same situation that was mentioned about Uganda, where they can't travel either, so they can't get in a car and go anywhere. You have to have a special pass, and the police stop you, and even just to go shopping. So it's good in a way that they really jumped on this, because as they say, if this got to the townships, it would be really a disaster because everybody is person upon person and there's no way to keep a distancing or any even sense of hygiene. It's really difficult. That goes for a number of places. You know, we began looking at a project in Jordan in the refugee areas. And again, people are packed together and there's really no way to have access to hygiene in a way that's going to be useful. So this is really problematic. I appreciate what Kevin was saying about Afghanistan. I won't speak any more about it because he really covered it quite well. But again, our staff is locked down there and looking for, I think, waiting. You know, I think there's just a lot of waiting now because nobody knows what's going to happen. And I have hopes that I will be going to Afghanistan to work in the prison sometime in the future, but I can't really say exactly when. And we thought, you know, before Dining for Women said that we can alter the program, we thought, well, okay, Herat was kind of hit worse because they have this proximity to Iran. And that border is very porous. And so a lot of the refugees that Kevin was talking about, they're coming through from Iran. And they brought with them COVID-19. It spread it was very small. And then it just expanded. I mean, it just was exponential. By the time Ashraf Ghani put said everyone has to stay put, nobody's allowed to leave Herat, it was too late. I think one person had already gone to Mazar-e Sharif and another person had gone to Kabul. So it just set it off. It's still not to the level that we're experiencing here, but still, it's still bad. And I think people are just hunkering down and waiting to see what they can do next, really. And, you know, there are still people out on the street because you have to make money, whether it's begging or whatever, you have to make money. And, you know, we have one program in the United States, and I'm wondering if even we could do that. And it's interesting because I'm surrounded by these health workers here on the panel. And it's in West Virginia, and it was to work on drugs because they have the epidemic of this drug addiction, the opioid drug addiction. And this has been really a pandemic in that area. So they were just double hit with this new situation. Now, West Virginia, oddly enough, I think has 2 cases of COVID-19, so it's really doing well in that regard. So I'm wondering whether we could even do that, work in our own country. I think what's going to happen is that as we wait and see what we can manage to accomplish in the next half a year. And, you know, if you listen to people, some people say there's not going to be anything happening for the next 12 months, 18 months, 2 years. You know, I mean, people have different levels of optimism here. I tend to be optimistic, and I hope that I'll be in South Africa in November working for the 16 days of activism against GBV. And I hope to be able to go back to Afghanistan soon and be able to do a project that we put off in Mexico on the border with Guatemala, working with the refugee population there. And also in Malaysia, which is the next coming up for Dining for Women, working with their winged women. Malaysia was pretty badly hit, so we'll see if that clears up before next year, because that was the project for next year and they're waiting. So, and that was to do a program on child marriage. So, you know, our projects tend to be women-based issues, not so much health-based issues, but it's also related that you can't avoid, you know, they complement each other, obviously. And we have another project on hold in Vietnam as well. So we'll see, and that's again to work with children mostly on issues of ecology, the local environment, because that's a very big issue in Vietnam. So that's what we're going to have, a very busy 2001 or 2002 if everything gets pushed off. And yeah.
Absolutely. Well, we are very optimistic too here at Dining for Women. We are going to continue to fight for women and girls. We're going to continue to support you the best way we can. So at this point, I'm going to take a little pause. I'm going to allow Wendy to ask our panelists some questions that our members have. The formal part of this presentation will probably end at 8:30. So let's give Wendy a chance to ask our panelists the questions. Wendy?
Okay, so I'm going to kind of go in the order that they were coming in. So first question is actually to you, Joanna. And it is, what other countries do not allow refugee rights as through the UN? If you could answer that.
Wow, I don't know if I could answer that really. I know that Malaysia was really, you know, kind of a dominant place because they were getting a lot of refugees from all over the Southeast Asia. So the project that we did was with a legal aid group. We partnered with Asylum Access. Asylum Access was presenting PowerPoint presentations about refugee rights to all of the refugee community. I think there's 21 different refugee communities in Malaysia right now, all in Kuala Lumpur and the environment. And so we translated that into a nonverbal enactment of everything that was in the PowerPoint so that we could go to every single refugee community in Malaysia to get this information about where they can go to get health care, where you cannot go, where you can get education. But I think I'll just have to look that up to find out what other countries have not signed on to the UN Convention on Refugees. I'm sure they're not alone.
Thank you, Joanna. The next question we have is for you, Peter. Can you address your work with AIDS and how it relates to the COVID-19 pandemic?
Sure. Our work on HIV has historically been focused on prevention and care, and so our current work on HIV is prevention focused, and so I mean, I think obviously there's a great deal of concern about communities at high risk for HIV or people living with HIV who are not on antiretroviral treatment, because we're worried about COVID and co-infection among people who are immunosuppressed. So there's a great deal of concern about that. Our HIV prevention projects, the essential parts of those services are still happening. One of the things that we do is provide pre-exposure prophylaxis for people who are HIV negative, so that the individuals who are enrolled in that project are able still to pick up drugs. They are able to move around and pick up drugs. So essential preventive services are still happening. But yeah, I mean, there's a real concern, and I think, as Mark pointed out, Uganda shut down really fast. Kenya shut down as well, not quite as quickly as Uganda did. And my concern isn't in the immediate term in sub-Saharan Africa. My concern is because they did react really, really quickly and put in place really strict social distancing measures. My concern is that eventually COVID is going to infiltrate the continent. It's going to happen, and that's my concern, is that COVID could be a real slow burn, and obviously, and particularly in sub-Saharan Africa, where you have the epicenter of the global HIV pandemic, you worry about people who are living with HIV and who are not on treatment. You worry about co-infection with malaria, obviously co-infection with TB. There are lots of comorbid diseases to worry about, and the lack of health systems. I'm just worried about that it'll end up being a slow burn, and eventually when it hits it, I just don't know how it's going to be contained. But yeah, so obviously we're concerned. There's not an awful lot that we can do on co-infection. As I said, we're trying to procure PPE for several of the counties where we work, and try to make sure that the health professionals at least have adequate PPE. We work in Nairobi, and there's a lack of PPE in Nairobi, and so if there's a lack of PPE in Nairobi, you can imagine what it's like in the rest of Kenya. there's a real dearth there. So I'm not sure I totally answered your question. I mean, it's a COVID HIV co-infection is certainly a concern. But as I say, at a minimum, our HIV prevention activities are, the essential portions of those HIV prevention activities are continuing, even amidst the pause, the pause in the rest of the programs.
Thank you, Peter. Now please, if you're not following the chat, please do follow it, because I love the fact that many of our members are jumping in with tidbits of information that they have or knowledge that they have, because our Dining for Women members are very knowledgeable. There's been a little bit of discussion on the chat, but I'll also ask it for those of you who are in Africa, and I know we've kind of got a concentration of Uganda and then Jenny with Togo, but the question is, aren't many African countries better prepared due to the fact that they've had to deal with Ebola and many other infectious diseases? Yeah. Do you think they're better prepared?
I think there's a distinction between preparedness and a quick response. So I agree with the comments that have been made that the response in a large number of African countries has been very quick. Preparedness is a different story. I think Mark put in the chat the ratio of care beds availability in Uganda, and that gives you a flavor for, if as Peter's saying, if cases start to grow, there is no treatment infrastructure for patients. The death rate will be significantly higher, and I think that's what we're all really, really worried about right now. And I think governments may have acted quickly because of experience that they've had with Ebola, but we just don't know if that's enough or for how long. One thing that is very concerning that we're seeing, not in Togo, but next door in Ghana, which responded very quickly, but then also very quickly reopened their borders and reopened movement in the country. And we have just actually last week with the celebrations around Ramadan, a big movement of people across the border and some positive cases that were detected subsequent. So how long will this quick response last? How long can we keep people locked down? We've talked a lot about the economic and social consequences that are resulting from that. So yeah, I think there's just a difference between the quick response and an actual ability to handle a high caseload.
Anyone else want to comment about Africa? Jenny, you described it very well. That I mean, while I was feeling a little bit relieved to hear about how quickly the countries have closed down, you're right. If they start opening up too soon, this could be scary, and it's really about the infrastructure in place to deal with it when the cases do increase. Next question I have is, for those programs that require people to be in close proximity to each other to do the work, as is the case with many of the projects we fund, what is the plan in light of possible long-term social distancing? Anyone want to jump on that one?
I can respond for HealthRight. A lot of what we do, as I mentioned, is community-based health system strengthening, and so it obviously involves a lot of group interaction. And so we've been going project by project and doing things like, the first thing that we've done is we've made sure that all of our staff have masks for when we do recommence our activities. The second thing is to limit the size of groups. So that's what I'm talking about when we're working with donors and adjusting milestones and targets. It may take longer than anticipated to hit some of our milestones and targets because we have to work just a little bit more carefully, a little bit more slowly in smaller groups than we otherwise would. And so those are some of the precautions that we're taking around interpersonal interaction.
Mm-hmm. Wendy, any more questions?
Yes. Are your programs, this is open to anyone, seeing an increase in gender-based violence due to the pandemic, and how are you addressing it?
I can answer that question, at least for our organization. We see an increase in the number of cases that are coming to us, and it's twofold. Part of it is that we work with women who are out of prison. Because of the pandemic, there's been a rush to let the prisoners out of prison, and most of these women, especially those who are charged with what they call moral crimes, have nowhere to go. The families disown them. So they are on their own. And so we all of a sudden feel that there's a huge demand for some of the shelters that deal with transition to the society. But also we have seen an increase in cases of domestic violence and the need for mediation, which coincides with the government's regulations to basically impose curfews on different cities. Makes it very difficult for people to have access to legal and justice system. And so we have been trying to put out different methods of communications in working with the government to ensure that during the time of crisis, anybody who needs us can reach us. And also going back to your previous question, we work with our centers, even though the government does not want the non-essential workers to open their doors. We have been arguing that our service is essential, especially in terms of the mediation and those individuals who need to have a shelter. So we have been working with the government. We have been teaching our staff how to deal with the clients in terms of before entering into the centers, they have to make sure that they do not have any fever, in terms of social distances, in terms of wearing masks, everything that we know will probably reduce the likelihood of the disease being spread. But also we requested to limit the number of clients we have on a daily basis. That way we are hoping to, again, limit the chance of the disease being spread throughout our centers and to our colleagues and our clients, hopefully.
Thank you, Kevin. The last question that I have in the chat is, will the average lower age of African populations help resist COVID spread?
Probably. I mean, I think that's the one thing that Sub-Saharan Africa has really has going for it in this pandemic, is that the average age, the average age is relatively young in most countries, and so we've seen lower mortality rates from COVID among younger people, and but then there's the lingering question, as I said, about the comorbidities and high prevalence of various other infections, and remember that there's a growing incidence of chronic disease across Sub-Saharan Africa too, growing issues with diabetes, cardiovascular disease, that sort of cancers. So yes, age is gonna, I think, will play a little bit of a protective role, but there are also factors that are deeply concerning once the pandemic sort of takes root on the continent. And I think that at some point the economic pain is just going to become too much, and the countries are going to be forced to open up. So yeah.
Absolutely. Wendy, can I go ahead and thank our panelists, and maybe perhaps Beth Ellen could wrap up after me?
Sounds good.
Okay, so if you are in the gallery view, I would like all our Dining for Women members to silently clap our appreciation to our panelists. Thank you so much for being here. Thank you so much for sharing all the information that you've given us about your own offices right here in the United States, recovering from COVID, all the pauses in your projects. We understand that this is an absolutely strange time, but perhaps it may spur a whole lot of innovation amongst all of us, we'll come up with new solutions and new ways of working with different communities. We can talk forever about all these topics, but I guess we should stop now. And Beth Allen, perhaps you would like to wrap this up?
Yes, thank you, Veena, for moderating that and asking wonderful questions. It is so inspiring to hear all of your stories and to be able to discuss the various parts of the world and how this is impacting people, and to have you in our living rooms and to ask you questions personally. It means so much to us. And so thank you to all of our panelists. And I'm so grateful for all of our members who are so interested in this. And I'm just filled with gratitude. So, and thank you to our staff who put this on, and to our board members for being here tonight. Everyone have a good night. Have a wonderful May Day. Go put some flowers in your hair. And May is going to be a better month. We can only hope. Thank you. Bye-bye. Great job, Veena.
Thank you.
That was really amazing stories.
Absolutely. Wendy, how many participants did we have?
I think you're on mute.
You're
Wendy.
muted. Wendy, you're muted.
I think we got up to
128.
Yeah.
You had 128. Wonderful.
Yeah.
Okay.
Good thing Gina spent that time this week to increase the Zoom license.
The limit. Yeah.
Because we would have been turning people away. But I mean, 218, 219 registered. Wow.
Wow.
Okay.
I wonder what happened to that.
Yeah, what happened to the people?
90 people. That's a lot of people to not show up.
Because most of them signed up today.
But you know what, Wendy? I don't know if you have been doing this, and if you haven't, tonight is the perfect night to start, is to send everybody the recording.
The people who, or just send it to everybody. Yeah.
Just send it to everybody. Because I often sign up for a webinar and I'm just like, I don't have time for this. I'm just going to look at it when they send me the recording.
I think, unfortunately, with our limitations on Outlook, it took hours today to send out these emails because you can only do 20 at a time, and you can't do them like the next minute. You've got to wait. So I'll send one, get it all ready, send one. I'll have them all ready, right? Send one, do a couple of other emails, send another. It takes a lot of time. So the recording will be posted on Facebook. It'll be posted on the website. Unless, you want to ask Sheila to help with that.
Well, maybe just a link to it on the website, and Sheila can send it out. And maybe we can figure out a different way to get that, I don't know, use MailChimp or something to get.
Well, yeah, that's true. We could, set up a whole MailChimp. But I'll post it on Facebook right away. And
okay. Beth Allen, can we have Sheila do some touch point thank you cards for our panelists?
Yeah, I was going to send them.
Okay,
so
whatever.
Yep.
Whatever.
Mm-hmm.
But it's almost like I have so many more questions to ask.
I know.
We could have kept going. We could have kept going.
I know. I really, the other thing that would be nice, Wendy, is if we sent a follow-up, and I know you can't do this tomorrow, but maybe I'll talk about it with Sheila, is to do a quick survey. Like, would people participate in something like this on a monthly basis? Would they, stuff like that, just a couple quick questions.
Mm-hmm. Wendy, I forgot to remind you to tell everyone how to save chat. You know, because
Right.
there was so much information in
Yeah.
the chat that some of them might have wanted it saved, but you know, we might be able to pull out some of the stuff.
I had people texting me after the meeting had started. I can't sign up. I forgot to sign up. Anyway, hi Gail, how are you?
Fine. I'm looking forward to sharing this with my chapter. It's going to be on May 5th, this when we're having our Zoom one. So I will tell all the chapters later, the people, maybe if you can even just tell the chapters to how they can tell people to view all of this.
Yep. Yeah, that's great.
Yeah.
Yeah, that would be wonderful. I think, yeah, and they can just skip to the point that they, you know, want to, you know, when the grantees started talking.
Yeah.
Mm-hmm. Mm-hmm.
How many chapters are actively participating now? Do you know?
Members we know, right? Chapters we don't.
Yeah.
Yeah, it's hard to tell because it's changing so fast, and that's the kind of thing that we track on a monthly basis, but we won't really know for April till about May 10th. And then by May 10th, things, because everything is moving so fast with COVID-19, things have changed so much, so.
Well, I look forward, Wendy, to seeing you on the book one.
Yes, I'll see you on Monday.
Yep.
What did you think of that book suggestion?
I think it's great. I'm just sorry that I don't buy many books. I'm a great library user. So I see that you have it. I've got a waiting list for to be downloaded from my library, but yeah.
Well, if I can read it real quick, I'll mail it to you.
Okay.
So Gail, do you have a smartphone where you can put Hoopla? Hoopla is an app.
I do have, yes.
Okay, so try and look up the Hoopla app, and you have to connect it to your local library, and then any of the books that they have that is downloadable or audible, you can listen.
I tried, because I got that message from my library, and I tried to connect them. For whatever reason, it wasn't working.
It's not working.
Yeah.
Sometimes they have to go into their system and mark you as current member.
Yeah.
So sometimes it's a library's kind of.
Yeah.
I was going to say, oh, drop by your library and they'll help you with it.
No, that's the problem. You can't even call them up. So
no.
Anyway, but it's great to just have you all out here. I mean, I wanted to say hi to the members and my mentor, Barbara Myers, who is on there. Just so many people on there at once. You can't just say hi, but you all do a great job. Thank you very much.
Thank you.
Thank you so much for everything you're doing, Gail. Well, you're just awesome.
Well, you all too. So
all right.
Take for a nice weekend.
Thank you.
Take care. Bye.
Thanks.
Wendy, is there anything we need to keep track of? I was not always reading the chat. It was distracting.
I was reading it. I don't think.
No.
Nothing.
There was nothing
okay.
concerning.
No.
Okay. Because I was so sure I was missing something. I would occasionally look at it and then I'd have to go back because I couldn't read it.
Yeah, no.
And it goes so fast.
It goes so
fast. It's like,
yeah. Well, then that's why I started writing down the questions when they came in, because otherwise I would never have been able to.
You cannot find it. You cannot find it again.
Did it work smoothly enough with, I mean, I did change the spotlight video each time as best as I could. Did it look okay?
Yes, I was on speaker view a lot. Yeah, so it was.
Yeah, on speaker view, like as long as people but a lot of people don't know that. I didn't know that for a long time. To put it on speaker view, but
well, I think that was a good point, and I mean, this was so much better than having a webinar with, even though, you know, if you didn't do the speaker view, your speaker might get lost or something if you weren't doing spotlight. It was just fantastic to see everyone there and chatting on the side, and we just would not have the same warm fuzzies with a webinar format. Yeah. So I thought it was.
I thought
it was so cool. I'm just emotional. I just thought it was amazing.
There were points I thought I
Wendy's
wouldn't
like-
be able to talk.
I'm sorry, I'm tired.
Yeah.
It was great. To
Yeah,
be honest,
right.
you know what usually happens with me, unfortunately, is I'm trying to do something else, like watch the chat or change the spotlight or whatever, and I don't hear all of it. But it was very good. Peter was great. You know, I liked hearing. You know, I wish we had had a few more different countries. You know, like somebody asked about India. Maybe somebody in India would have been good. But we can always do that for a future one. And no, it was great. So yeah, I'm going to say goodnight.
Yep. Me too.
Have a really good day off.
Yeah.
Please don't look at your email.
Well, I have to. I've got to get the dish out tomorrow. So if you can look at it in the morning and just send me any comments, I'll probably send it.
I'll look at it right now and yeah, I'll look at it right now.
Okay.
So it'll be
All right. Thank
Good
you.
night.
All right.
Good night.
Good night.